which one's stable, early weight bearing can be a consideration, but you really have to go what your comfort level is. So there's many distal osteotomies. We're gonna talk about the chevron and the Austin, which are the two most common that are done in this country. So these are usually done for mild to moderate type bunions. This is more of a translational type osteotomy. It shouldn't be done for severe bunions and certainly shouldn't be done for significant pronation. It's classically described as 60-degree angles from the center of the metatarsal head. If you can make the dorsal limb a little bit longer, it certainly gives you better fixation. You want to avoid over-penetrating laterally where you can disrupt the artery and might lead to avascular necrosis. You're able to shift this fragment probably up to 6 millimeters. And then fixation, you can use K-wire, you can use screw, bioabsorbable pin, you can use a plate. I've done all of this except plates. Started out with K-wires. Patients hate K-wires sticking out of their foot. Went to screws, used an absorbable fixation for a while. I've never done this. I don't know. This is supposed to add stability using these kind of plates. I think what it does do is it leads to a lot of hardware removal. So there's no evidence to support one type of fixation over the other. We certainly want to avoid, however, these non-unions. The last thing you do with any of this, with all these osteotomies, is tighten the medial capsule. And you really don't want to get your final X-ray until after you've tightened that medial capsule, because you may end up not having corrected it completely, that you can correct somewhat with tightening the capsule, or you may overcorrect it into varus.